that should be more than equal to 200 milligram percent. Number 3, HbA1c level. এটা কিভাবে দেখতে হয় তারও স্ট্রিক্ট ক্রাইটেরিয়া রয়েছে। HbA1c level more than equal to 6.5%, or if the patient have classical symptom of hyperglycemia like polydipsia, polyphagia and a random plasma glucose is more than equal to 200 milligram percent. In any one of these conditions, if positive, the person is diabetic. Now, how we classify diabetics? Diabetes can be type 1 diabetes. It is commonly seen in children, also called insulin dependent diabetes mellitus, although the term is obsolete. Now, it is caused due to autoimmune destruction of beta cells, so that insulin secretion in the body is decreased. Number 2 is type 2 diabetes mellitus, is the most common one seen in more than 90% of the diabetic population, generally late onset, more than 35 years of age. It occurs, the primary pathology is insulin resistance, that is the peripheral action of insulin is decreased. In the long run, the beta cell failure or beta cell destruction also occurs. Now, number 3 is specific type of diabetes due to other cause, like it can be drug induced, it can be due to the genetic cause, it can be due to the defect in the exocrine pancreas. Then gestational diabetes mellitus, it is seen in the second or third trimester of pregnancy. Type 1 diabetes mellitus, also called insulin dependent diabetes mellitus, basic pathology beta cell destruction in the pancreatic islets. Now, it can be again of two types. Type 1A, because of autoimmune cause, majority are type 1A, and some are idiopathic, type 1B. Now, here the circulating insulin levels are low or very low, and the antibodies are positive. These patients, because they are insulinopenic, the blood level insulin are very low, they are very prone to ketoacidosis. It's less common, low degree of genetic predisposition that does not run in families. Type 2 diabetes mellitus, it is also called non-insulin dependent diabetes mellitus. Over 90% of the cases of diabetes are type 2 diabetes mellitus. Now, basic pathology insulin resistance, although in the long run patient becomes insulinopenic, insulin secretion is decreased, generally has a late onset, more than 35 years of age. Insulin in circulation is low, normal, and can even be high. No anti-beta cell antibody is demonstrable, unlike in case of type 1 diabetes. Has a high degree of genetic predisposition, they run in families. Now, pathophysiology of diabetes mellitus. Mind it, glucose in the body, they are strong regulator of insulin from the pancreatic beta cells. Now, if there is abnormality in the glucoreceptors of the beta cells, so less insulin secretion will be there and may progress to beta cell failure. This is the number 1 pathology. Number 2 is reduced sensitivity of the peripheral tissues to the insulin, that is down regulation of insulin receptors, shown by insulin resistance. Excess of hyperglycemic hormones, particularly glucagon, and obesity, they all lead to relative insulin resistance. In most cases, however, both insulin resistance and beta cell insufficiency are produced by a combination of genetic and environmental factors. Now, nowadays, the basic pathophysiology of type 2 of diabetes mellitus is shown by ominous octet, where the defect can be in the pancreas due to decrease in insulin secretion. The defect can be in the gastrointestinal tract, when the glucose is taken orally from the intestine. Some enzymes are secreted called incretin that include glucagon like peptide 1 GIP, VIP and others. Now they also help in the secretion of insulin from the pancreas. So decrease in incretin effect can lead to that. Increased lipolysis can cause hyperglycemia because of gluconeogenesis. Increased glucose reabsorption from the kidney. Decreased glucose uptake from the peripheral tissues. Neurotransmitter dysfunction from the in the case of brain pathology, that can also lead to hypoglycemia. Increased hepatic glucose production can lead to hyperglycemia. Increased glucagon secretion from the pancreas. Now approaches to the drug therapy in type 2 diabetes mellitus. Number 1, by improving the insulin availability, and number 2, by decreasing the insulin resistance. So by improving insulin availability, the drugs are insulin, sulfonylureas, they cause increased secretion of insulin from the pancreas. Meglitinides, DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors, and GLP-1 receptor agonist, that is glucagon like peptide 1 receptor agonist. We will come one by one to each of them. Now today we will be discussing only on insulin. Now these are the drugs, they improve insulin availability, except other than DPP4 inhibitors and GLP-1 receptor agonist. The major limitations of these drugs are multiple daily injection for insulin, hypoglycemic episodes are more with these drugs, except DPP4 and GLP-1. Weight gain, concern about premature atherosclerosis due to hyperinsulinemia. Now, the drugs which overcome insulin resistance are big one eyes, that include metformin, the only drug clinically used nowadays. Thiazolidine diones, that include pioglitazone, is the only drug available right now. Alpha glucosidase inhibitors like voglibos. Major limitations in inability to achieve normoglycemia by themselves in many patients, especially moderate to severe. So সেখানে কিন্তু one of the drugs from this group is required. Now the drug that has not been mentioned here is SGLT2 inhibitors. They decrease the glucose reabsorption from the kidney and thus help in the control of diabetes. It is a newer drug being used in diabetes and in non-diabetic subjects having heart failure and kidney disease. Now coming to insulin. Insulin was discovered in 1921. Before that, before 1921, a patient having diabetes that was destined to die because no drug was available at till that time. It was Banting and Best who discovered insulin. They discovered insulin in 1921 by demonstrating the hypoglycemic effect of the extract from dog pancreas. Now, pure crystalline form of insulin was obtained in 1926 and the chemical structure of insulin was first delineated fully in 1956 by Sanger. Now coming to structure of insulin. Insulin is a peptide hormone having is a polypeptide hormone having two peptide chains. They have got A chain and B chain. A chain is having 21 amino acids while B chain is having 30 amino acids. They are joined together by two disulfide bonds. Now, before the advent of human insulin, pork and beef insulin were used. Now, these are the subtle differences in the pork, beef and human insulin. In the A chain, 8th amino acid, human insulin, they have got threonine. Pork, they have got threonine, but in the beef insulin, A chain, 8th amino acid, alanine is there. In the 10th amino acid, again human have got isoleucine. Pork insulin have got isoleucine, but the beef insulin, they have got valine. In the B chain, 30th amino acid, human they have got threonine. Pork they have got alanine, beef they have got alanine. So what to be noted here, that pork insulin more or less resemble that of human insulin, and hence they are lesser immunogenic compared to the beef insulin. Now, synthesis of insulin. Insulin, as we know, are synthesized in the beta cells of the pancreatic islets. Now, first the polypeptide chain pre-proinsulin is synthesized, having 110 amino acids. Is a single polypeptide chain. From that, 24 amino acids are first cleaved to form proinsulin. Now, this proinsulin is a single chain. From the middle, a peptide is cleaved off containing 35 amino acids. This cleaved off peptide is called connecting or C peptide. And after cleaving off, the two amino acid chains, A and B chains, are formed, which form insulin. This insulin and C peptide, they are stored in the granules within the beta cells, islets. And when the insulin is released in the body, insulin is released along with the C peptide. Now, regulation of insulin secretion. The insulin is secreted in the body in the presence of various factors. They can be grouped into chemical, hormonal and neural. Now, coming to chemical regulator, glucose is the primary principal regulator for insulin secretion. Now, what happens when glucose enters? It is by glucokinase, it is converted to glucose 6 phosphate, and by a series of reactions, ATP is generated. This ATP causes efflux of potassium by the potassium sensitive ATP channel, ATP sensitive potassium channel. Now, that leads to in-drive of calcium, influx of calcium through the voltage sensitive calcium channel, and that is leading to the exocytosis of the insulin from the pancreatic beta cells. So, glucose is the principal regulator. Other nutrients that can evoke insulin release are amino acids, fatty acids and ketone bodies. Now, glucose that is administered orally and that is administered intravenously. The one which is administered orally, that invoke release of insulin 2 to 4 times than when glucose is administered intravenously. Why? This is because when the glucose is administered orally, incretin hormones, incretins, they are generated. They include GLP-1, GIP, VIP and pancreatogymin cholecystokinin from the gut, which also act on the beta cells of the pancreas, causing insulin release. These are the intestine. Here the glucose is taken up, incretins are formed, incretins reaches the beta cells and causing release of insulin. Number 2 regulators are hormones. We all know that a number of hormones like growth hormone, corticosteroids, thyroxine, they modify insulin release from the pancreas in response to glucose. The more important thing is that a number of hormones, they are produced from the pancreatic beta cell itself. They include insulin, glucagon, somatostatin and others. And there are intra-islet paracrine interaction between the hormones. Now, these are pancreatic beta cells. In the center, there are cluster of beta cells that comprise around 70% of the cells. They secrete insulin and amylin. Then at the periphery, there are alpha cells. These constitute around 20% of the cells. From the alpha cells, glucagon is secreted. And in the center, some delta cells are there, around 10%. They release somatostatin. There are also epsilon cells and gamma cells. Now, this somatostatin, they inhibit release of insulin and glucagon. Now, this glucagon, they increase the release of insulin and as well as somatostatin, and insulin, they inhibit glucagon secretion. Amylin, another beta cell polypeptide, they also inhibit insulin release by central action. Now, neural, the islets are richly supplied by the nerves. Now, the adrenergic alpha 2 receptor activation, they decrease insulin release. causing hyperglycemia by inhibiting beta cell adenylyl cyclase, and muscarinic activation by acetylcholine or vagal stimulation. They cause insulin secretion through IP3-DAG pathway, increasing intracellular calcium. Action of insulin. Now, insulin, their primary action is to dispose meal-derived glucose, amino acid, fatty acids and store them as a fuel. Now, it is a major anabolic hormone. They promote storage of the protein, fat and the carbohydrates. Insulin, number one, insulin facilitates glucose transport across cell membrane, particularly skeletal muscle and the fats. They are highly sensitive to insulin. However, liver, brain, RBC, WBC and renal medullary cells, they are independent of insulin action for glucose uptake. Ketoacidosis interfere with glucose utilization by brain and can lead to diabetic coma. Now again, there are glut transporters, glucose transporters called glut, GLUT. Now they are stored in the vesicles, in the cells. Now insulin, they promote the translocation of glucose transporters from the cytosol to the membrane, so that the glucose can be uptaken by the cells, and glucose transporter 4 is highly sensitive to insulin action. Now again, in the action of insulin, inhibit the lipolysis and prevents triglyceride synthesis. Now in the diabetic subjects, the fat is broken down by the unchecked action of lipolytic hormones, leading to increase of free fatty acids and glycerol. Now these are taken up by the liver to form acetyl-CoA. Now in diabetic subjects, because of absence of insulin, acetyl-CoA is not good for resynthesis of carbohydrate, but they are diverted to form ketone bodies, that is ketonemia and ketosis. Again, the insulin enhances transcription of vascular enzymes, lipoprotein, thereby accelerating clearance of the cytomatomes and PNDA. Insulin also facilitates amino acid entry into the muscles and the other cells. Hence, the protein in diabetic subject, protein breakdown is increased, leading to more amino acid in the blood, which are taken up by the liver to form fibrate, glucose and urea. Excess urea is excreted in urine, resulting in negative protein balance. Now, most of the actions that are discussed are rapid. For rapid actions, they are related to agents of units. Some actions, like increased secretion of glucose transporter and some enzymes of amino acid metabolism, they involve DNA. They are inserted in few hours for intermediate actions, and some measure some long-term effects on multiplication and differentiation of cells. Now, how does insulin measure hypoglycemia? By their action on liver, muscle and hypoglycemia. In liver, they are increasing the glucose uptake and utilization. They are inhibiting glycogenolysis and glucose output, and they are inhibiting gluconeogenesis. In the muscle, increased glucose uptake and utilization and inhibiting proteolysis. In the adipose, by inhibiting glucose uptake and inhibiting glycolysis. Now, how does insulin active? Mechanism of action of insulin. The insulin receptors, they are basically receptor tyrosine kinase. Now, it is an heteroextrametabolic structure containing extracellular subunit alpha and two transmembrane subunit beta. Now, this alpha subunit, they have got, they are linked by disulfide bonds. Now, this alpha subunit, they have got binding site, and the beta subunit, they have got tyrosine residues. Now what happens when
internalized between the reaction. And what happens? There is phosphorylation of the tyrosine residue at the beta subunit terminal. Now this expository category site causing phosphorylation of the insulin receptor substrate. What happens? Now this phosphorylation of the insulin receptor substrate, they causes a cascade of phosphorylation and dephosphorylation mechanism, causing stimulation and inhibition of several metabolic enzymes causing the action of insulin. Again, insulin, they causes translocation of the blood and glucose transporter 4 from the cytosol to the membrane, backed by the ADP. Now, this cascade leads to generation of second messenger PIP3 that also involved in the inhibition and stimulation of several enzymes. Also, via the RAS pathway and MAC pathway, due to the stimulation of the gene, the synthesis and inhibition of several enzymes occurs. Now, after insulin action is over, when the receptor is internalized, either they are degraded in the cell or they can be translocated to the membrane. What will happen? The fate of the insulin receptor indicates on the type of on the site where the insulin receptor is located. In liver, most of the receptors are degraded, while in vascular endothelium, most of the receptors are translocated to the membrane. Now coming to the fate of insulin, as you know, insulin is a polypeptide form, so they get integrated in the gastrointestinal tract if they get orally. So insulin is not taken up orally, it is parenteral. Now injected or that group of bacteria primarily got metabolized in the liver, thus can be metabolized in the kidney and muscles. Now, how it degraded? Basically, the disulfide bond is broken up. The two A and B chains are separated, and they are metabolized in the constituent amino acids. Alpha half of insulin is 5 to 9 minutes. Now, coming to degradation of insulin, before the advent of human insulin, bought and mixed insulin is used. Now, the older commercial degradation of insulin contains 1% of other proteins. That includes proinsulin, other polypeptide, magnetic proteins, insulin derivatives, problem, anti-resistance, causing inflammation, potentially antigenic. They are no longer produced and have been replaced by highly purified and insulin, recombinant human insulin and analogs. In 1970s, improved purification techniques like gel filtration, ionic chromatography were applied to produce either single peak or monocomponent insulin that contains very less amount of other proteins. Now, monocomponent insulin are more stable and are less and cause less insulin resistance. Now, the types of insulin preparations available in the market are: number one thing is bacteria-active insulin. They include insulin Lispro, insulin Aspart, and insulin Tulis. The short-acting insulins are regular or soluble insulin. Intermediate-acting insulin are insulin being sensitization, also called lengthy. Neutral protein method, that is NP-based insulin. Also called isoprene insulin. Long-acting, they include insulin glargine, insulin native, and also insulin day-to-day. Now coming to regular or soluble insulin. Number one thing, the solution prepared of the insulin is neutral. Number two, they are unmodified insulin and they are stabilized by a small amount of G. Now, at a concentration of injectable solution, they are present in hexamers with zinc ion at the center. Now, when they are injected subcutaneously, the হয়েছে যখন পেশেন্ট ফাস্টিং হিসেবে আছে তাতে একটা বেসাল গ্লুকোজ স্টেট থাকে সেটাই কন্ট্রোল করতে হবে এটাকে বলা হয় ফাস্টিং গ্লাইসেমিয়া ঠিক আছে now the problem with this type of insulin is that they are short acting they act only for 6 to 8 hours so they are taking care of only mean hyperglycemia not fasting hyperglycemia okay now optimally injected 1 hour before a meal and very important regular insulin is the only insulin that can be injected intravenously not any type of other insulin like I don't know a patient with hyperglycemic insulin hyperglycemic state like diabetic ketoacidosis they are using only soluble insulin not other type of insulin regular insulin is not suitable for providing a low constant basal level of action in the interdigestive period. To overcome the above problem, some long-acting modified or retarded preparations are taken to take care of fasting hyperglycemia. Now, for obtaining retarded preparations, 2 measures are taken up. Number 1 thing by complexing the insulin with glutamine, and number 2 by using excess of zinc ion causing precipitation of insulin and increasing the particle size. যেহেতু রেগুলার ইনসুলিনটা fasting hyperglycemia control করতে পারছে না the modification to take it up so that the preparation can be long acting. For that, two types of measurements used either increasing the zinc concentration so that insulin will get precipitated and smaller amount of insulin is released slowly so that it can be long acting. Number 2, glutamine was complex with the insulin molecule so that the insulin is released in the circulation slowly. These were two mechanisms by which the insulin solution was made long acting. Now, negative insulin are basically insulin zinc supplements. There the zinc concentration has been increased. Now, two types of insulin zinc supplements have been produced. One is the larger particle size. They are called ultra lengthy. They are long acting. And one is the smaller particle called semi lengthy. They are short acting. Now, 7 liters of ultra lengthy and semi lengthy they produce anti-insulin. It is intermediate acting. They act for 12 hours. Now, coming to isoprene or MBBS insulin. Now, these are here basically the insulin molecules. They are complex with glutamine. Now, glutamine is added in a quantity just sufficient to this complex all the insulin molecules. Neither the insulin nor the glutamine in the free form, and the pH of the solution is neutral. On subcutaneous injection, the complex dissociates slowly to create an intermediate position of action. Now, they are mostly combined with regular insulin in 70, 30 or 50 to 50 and injected sometimes twice daily. একটা ডায়াবেটিক পেশেন্ট কন্ট্রোল করার জন্য ডেল টাইম গ্লাইসেমিয়া কন্ট্রোল করতে হবে আর ফাস্টিং হাইপারগ্লাইসেমিয়া কন্ট্রোল করতে হবে তার মধ্যে দুটো টাইপস ইনসুলিন রিকোয়ার্ড one is short acting one is long acting now in this preparation basically we are combining the MBBS insulin which is intermediate acting that act for 12 hours and combining the regular insulin which act for 6 hours 8 hours so by combining these two can take care of both the fasting hyperglycemia and the mean hyperglycemia. This is what is regimen. Now coming to human insulin, in 1980s, human insulin was produced by recombinant DNA technology by E. coli, by yeast and by modifying enzymatic modification of porcine insulin. In USA, what are no longer used. But it is still available in UK, India and the European countries. Although in India, human insulin and analogs are commonly used. Now, human insulin is more water soluble. They are likely having more rapid subcutaneous absorption, earlier and more defined peak concentration, and slightly shorter duration of action compared with the and the big insulin. Now also modify like that of other insulins, they can also be modified to isolate and negative preparations. Now negative human insulin is no longer as prepared in US. Now coming to insulin analogs. The insulin analogs basically are the modified human insulin by a man, so that they have got an additional pharmacokinetic advantage. Okay, with having similar pharmacodynamic actions. So, using recombinant DNA technology, insulin analogs have been produced, which are modified pharmacokinetics on some specifications, but similar pharmacodynamic and immunogenicity. They have also greater stability and now, insulin analogs include short-acting, insulin lispro, insulin aspart, insulin glulisib, and also long-acting insulin analogs are there. Insulin glargine, insulin decadin, and insulin degludec. These are insulin analogs. In insulin lispro, the B28 amino acid is basically proline, and B29 amino acid is lysine. They got taken reverse. So what happens? The hexamers which are present in the normal soluble insulin, they are very big hexamers and they dissociate rapidly after some inhibition. So they are ultra short acting. They are resulting in a quick and more defined peak in the shorter period of action. They are injected 0 to 20 minutes before a meal. That is more convenient. The soluble insulin এখন কাকে দিতে হয় আর মাত্রাকে এখন better control of anti-glycemia when a meal is taken the hyperglycemic peak is going to be 1 and the gastric is outside here. Now the soluble insulin peak of action by 3 hours and action persistent for 8 hours. So the hypoglycemic chances are low. Now coming to this insulin is pro. Basically, the peak it will indicate the position in 0 to 20 minutes. It action for 3 to 6 hours. The action is short. So hypoglycemic chances are less with insulin is pro. Better control of anti-glycemia and lower incidence of post-prandial hypoglycemia. Insulin aspart. Now here the B28 proline replaced by aspartic acid. Now the pharmacokinetic formula is combined as similar to that of insulin lispro. By placing insulin aspart, here the insulin molecule is complex isoprene and a complex insulin isolate with uncomplex insulin aspart in a 70 to 30 ratio in by placing insulin aspart. The advantage rapid and predictable onset along with intermediate duration of action. Insulin glulisib. Here basically at the peak terminal, lysine replacing asparagine at B29, glutamic acid replacing lysine. Property similar to insulin lispro. Now in type 1 diabetes particularly, insulin pumps are used. That is what continuous subcutaneous insulin infusion pump, and in those cases commonly insulin glulisib is used. Insulin glargine. Now coming to long-acting insulin analogs. These are long-acting biosynthetic insulin. Here two additional arginine residues are added at the carboxyl terminus of butane, and at 821 glycine replaces arginine. Now this insulin analog, they have got acidic, they are soluble in acidic pH. Now when injected subcutaneously, they come in contact with the neutral pH. They precipitate a depot is created, prompting the protein insulin released slowly. Because of this, it becomes long acting. Duration of action is around 24 hours. And that has to be injected once daily. Because of acidic pH, it cannot be injected with any other insulin preparation. Now, it is suitable for once daily injection to provide back at P29. Now what happens when they are injected subcutaneously? Albumin, if they bind to the albumin and the free insulin is released slowly, so they are not active. Duration of action around 20 hours. A pattern of insulin action almost similar to insulin therapy, but twice daily activity. Insulin Degludec is an ultra long acting insulin analog and duration of action around 40 hours. Now, after single daily injection, day-to-day variability of the response, day-to-day variability and risk of nocturnal hypoglycemia are lower compared to insulin glargine. It is also been co-formulated with rapid acting insulin antibody, unlike glargine, which cannot be co-formulated with other insulin. Now, side effects of insulin or reaction to insulin. Number one, very important, hypoglycemia. Then, local reactions are there, allergy and edema. Hypoglycemia is the most frequent and most dangerous complication. Local reactions, injection is given at the local site edema and stinging sensation may occur. And very important, hypoxia of the subcutaneous fat, they are located seriously with the older preparation of insulin, but with the advent of newer insulin preparations that are decreased. Allergy, that due to the contaminated proteins, very rare newer insulin preparations. Urticaria, angioedema, and anaphylaxis can be the manifestation of allergies. Edema, in some cases, edema may develop to insulin therapy due to sodium deficiency. Now coming to hypoglycemia. Hypoglycemia is the most dangerous complication of insulin therapy. Hypoglycemic episodes are more common in labile diabetes. What we mean labile diabetes? Basically, there is insulin department in the patient. Blood insulin dangerous. Accidentally, insulin large accidentally and lost it over here. Now, these patients are very prone to develop hypoglycemia and it is more common in type 1 diabetes. Now, causes of hypoglycemia, number one, labile diabetes. Number two, following inadvertent injection of large dose. Loss of impact of food age, that can be hypoglycemia. Patient insulin needs metabolic acid, that can be hypoglycemia, missing a meal, or performing rigorous exercise. These are all the causes of hypoglycemia. Now, what are the symptoms of hypoglycemia? The hypoglycemic symptoms can be divided into two groups. One is antidiuretic symptoms because of sympathetic stimulation leading to anxiety, palpitation, brain. These are also called warning signs of hypoglycemia. And the patient diabetic retinopathy, insulin নেওয়া পর যদি হাতটা কাঁপে দরকার হয় ঘাম দেয় মানে সুগারটা কতটা কমে গেছে আইদার কোনো কিডনি থাকলে খাও এই সুগার থেকে বা প্যাসিফিক থাকে সুগার বিকল তো this is the warning signs of hypoglycemia. Dangerous hypoglycemia may ensue if not taken care of properly. Now, the second is neuropsychomotor symptoms. They occur due to deprivation of brain of glucose. Now, what are the diseases? Headache, behavioral symptoms, visual disturbance, hunger, fatigue, weakness, muscular coordination, and hypotension. Generally, adrenal symptoms precede over the neuropathic symptoms. These are called warning signs. Now, in this case, warning signs may not be present. Number one, advanced stage of diabetes, where is diabetic, autonomic neuropathy. So, this pathogenic symptoms can be absent. Number two, patient on beta blockers, particularly non-specific beta blockers. The hypoglycemic warning symptoms can be marked. And then, when the patient is suffering from frequent episodes of hypoglycemia, that can mark warning signs of hypoglycemia. Now, when the blood glucose level was below 40 mg/%, the patient can have mental confusion, abnormal behavior, seizures, and coma. And if the hypoglycemic symptoms are not taken care of, in case of prolonged hypoglycemia, irreversible neurological deficiency occurs. Now, how to treat hypoglycemia? How to treat hypoglycemia? conscious, we will be giving the glucose orally. We will be able to take the meal. How much? Around 15 to 20 grams of glucose orally. For any carbohydrate level, people like sugar can be levels. And in most of the cases, symptoms are reversed. Improvement can be treated again. Now, if the patient is not able to take the drug orally or is unconscious, then the glucose is injected intravenously. 15% glucose solution is taken around 50 ml and infusion for 10 to 15 minutes. Alternatively, in unconscious patient, where glucose solution is not available, glucagon can be injected 1 milligram IV. Other than that, aspirin can be used, but are less challenging. Now, drug interactions. Number one, beta blockers. Two interactions are there. Number one, they are masking the hypoglycemic symptom of hypoglycemic symptoms of insulin. Number one, so that basically hypoglycemia. Number two, they are prolonging the hypoglycemia by inhibiting compensatory mechanism operating to beta 2 system. These are two interactions of beta blockers with the insulin. As I introduced the mind cortical steroids, both in the therefore and metabolic, they increase blood sugar level and can decrease the efficacy of insulin. Acute ingestion of alcohol can cause hypoglycemia by depleting the hepatic glycogen. And finally, lithium hydroxide they can increase hypoglycemia by enhancing insulin secretion from the pancreas. As well as peripheral glucose utilization can be increased. It asks you